So for laboratories that perform both genotypic as well as phenotypic methods for antimicrobial susceptibility testing, it's really important to just note that there will, of course, always be opportunities for discrepancies between these platforms. And when we see discrepancies in AST, we always have to be cognizant that there is the potential for harm to a patient. And the common examples of harm related to inappropriate or related to errors in AST are inappropriate de-escalation of broad-spectrum antimicrobial therapy, or conversely, unnecessary exposure to broad-spectrum antimicrobial therapy when more targeted therapy would be sufficient. Additionally, as a result of some of the identification targets that are present in many of these syndromic panels that feature genotypic AST methods, these assays can fail to accurately identify polymicrobial infections. And lastly, related to genotypic AST, the lack of certain on-target antimicrobial resistant genes can lead to discrepancies between the genotypic and phenotypic AST results that are obtained. So some classic examples that I'm sure many people have seen in their laboratories would be things like this first scenario in this table, where there's a positive blood culture that upon gram stain reveals gram-positive cocci clusters that were found in multiple bottles and sets. Doing a direct blood culture ID test, you see there were results obtained for the Staphylococcus target of DNA that was detected. A specific target for Staph aureus was detected, and then the MEK-A gene target itself was detected. So one would naturally assume that your patient has Staph aureus bacteremia that is methicillin resistant, or an MRSA. However, after overnight culture and identification of and performing traditional AST, the culture is growing colonies of Staph aureus that were found to be oxacillin susceptible. So it's an MSSA isolate. And in one of those bottles from the set, there was a second isolate, Staphylococcus epidermidis, that was growing that was found to be oxacillin resistant. So it was an MRSC. In this example, you would have a patient who may have been continued on vancomycin therapy for a presumed MRSA based on those genotypic results, when in fact the MEK-A target was in the Staph epi that was likely a contaminant because it was only found in one out of the 2 sets of blood cultures.